Today I'll start off our talk about the I-ELCAP initiatives. And as Dr. Yankelowicz said, I'll be joined by my colleague, Rowena Yip, after I give a little bit of an intro. We don't have any disclosures. So as many of you know, and maybe some of you don't, I-ELCAP has been in existence for over 25 years. And it's one of the hallmarks of I-ELCAP has been its focus on collaboration. First starting in the New York area and then expanding to the nation and then the world. So we have partners all over the world. And what we'd like to do here is to spark some new collaborations with our existing partners and maybe with new partners who currently aren't with I-ELCAP. And I just wanted to go over some of the things that we use to kind of help facilitate the research. We provide an infrastructure for the data collection, and we also wanted to discuss some of the ongoing projects and organizations that we're working with. So one of the cornerstones of I-ELCAP and the work that we've been able to do in lung screening has been made possible by large-scale data collection, and that's been primarily done through the I-ELCAP management system. It's a web-based system that collects high-quality and comprehensive data that supports lung cancer research and clinical management. This is, I won't say it's the first, but I say one of the first, but it probably is the first management system in existence. And it has been successfully running programs across the world for over 20 years. It provides some capabilities for participant follow-up. It uniquely, I think, even compared to a lot of commercial lung screening management systems today, stores the image and will automatically generate a report from the form data that's entered. So I'm going to just show a quick screen cap of what the system looks like. So this is just a very small snapshot of the data that we collect for the lung nodules, including things like the location, the size, and consistency. And like I said, this is a very small portion. But what we can do is, even once you fill out this form, we can then generate a report, a textual report that you can then import into PowerScribe. So it kind of fits into existing workflows. But the fact that it's structured and it's in a form like that makes it very consistent, makes it high quality. We do data quality checks when you enter the data to make sure you're not putting in, a letter instead of a number and things like that. Due to kind of the success of the I-ELCAP management system, it was adopted by the VA as part of the VA PALS I-ELCAP project. It's an open source system, and you can see the source for the system on this GitHub repository link. It's been customized for the workflow of the VA, but here you can kind of see some of the modifications, some of the forms that we've modified. And I just wanted to also mention that this was supported by a grant from the Bristol Myers Squibb Foundation. We also took this and extended it past, we took the VA system and we extended it to a more general lung screening management system, which we call Screening Plus. And it does a lot of the same things as the VA PALS system does, but what we like to focus on is that it's very customizable. Unlike a lot of commercial systems where what they give you is what you get, we can modify the forms, we can do a lot of other things, and Rick Avila can speak more to that. One thing that we're excited about and that we've got working with at least one vendor is the integration with AI systems. So earlier on, you saw the form with the nodule, the area where you fill out the nodule information. Well, now we can integrate with, we have an open API that can integrate with any vendor that chooses to follow it, to automatically fill on the right there that it shows a little snapshot of what the AI is finding. It fills out the form, and then you can kind of, the radiologist can accept or reject that. And we've got it working with the Siemens AI RAD Companion so far, but we're also working with other vendors as well. And as part of our effort to open source it, we've also open sourced our data dictionary so that we could hopefully have a common set of data elements that all lung screening management systems will use. So this will make data interoperability much easier in the future. We've also developed an education initiative, which we call a teaching file. And we wanted to make this as easy to use and as globally accessible as possible. We're transitioning it to being hosted by the IESLC. And the main leads on this are Dr. Shaham and Dr. Chipuadet. You can contact them for more info or if you want to contribute. We're looking for contributions from everybody. And now we're going to talk about some of our research projects. I'll turn it over to my colleague, Rowena.
Hi, good afternoon. I'm Rowena Yip, and this afternoon I'm going to talk about some of the research projects that we are working on with I-ELCAP partners. So I'm going to cover 5 main topics. I'm going to go over the first 3, and Artit will talk about measurement uncertainty, and then I'll come back to talk about the impact of duration of follow-up. So the first topic is shared decision making. The rationale for requiring shared decision-making in lung cancer screening stems from the concern regarding the net balance between in lung cancer benefits of screening and the harms of getting CT screenings, and to the belief that this process leads to more informed decision and better health outcome. However, the process can be time-consuming, and some institutions rely on centralized approach where the shared decision-making SDM is conducted by someone other than the referring physician. So in this first project, we want to evaluate the impact of this centralized approach had on the participants and also the referring physician. We recruited 24 screening participants and 12 physicians to participate in these interviews. All screening participants here had already undergone the shared decision-making session with a nurse practitioner, and the interviews were conducted by an outside researcher firm. For the participants' interview, we explored the extent of their satisfaction with learning about the screening process and the impact of their having the process explained to them by someone other than their referring physician. And for the physician, we were interested in their comfort level with referring their patients to a centralized SDM and whether they themselves felt comfortable with shared decision-making and the elements included in it. So among the 24 screening participants, over half of them, you can see the pie chart on the left, more than half of them felt that their referring physician did not have sufficient communication with them prior to the referral. Among the 24, 2 actually declined screening, and the remaining 22 underwent screening. But all of those that underwent screening found the decision to be easy. It was primarily based on their perception of their physician's recommendation as well as their understanding of the screening benefits. So for the referring physician, they all understood the USPSTF criteria for lung cancer screening. Majority of them considered lung cancer screening to be of equal or greater importance other than the cancer screening. While they recognized the requirement for SDM conversation, they did not have a common understanding of the elements. Only half of the physicians felt that they understood how shared decision-making should be carried out, and 4 felt that they were not familiar with the requirements. So in summary, for this project, the use of centralized shared decision-making was meant to alleviate time constraint from the physician, but we have now seen that it has also led to physicians having inconsistent knowledge of the process. Additionally, even though that the relevant information was provided to the screening participants in the centralized process, but the participants still perceive a lack of communication with their physician. For participants who opt to undergo screening, they believe that the decision was in essence already made for them to enroll before the SDM encounter, therefore notifying the very essence of the SDM process. So in the second project, we looked also with Genentech, we look at the impact of magnitude of lung cancer screening benefits. We want to examine the perceived benefits of CT screening for lung cancer for the patients and also for the physician. We want to assess how different communication strategy regarding the benefits of CT screening might impact the physician and in referring patient into screening program, and also for participants who are interested in screening, how they would react to these different strategy. We're using the same 24 participants and 12 physicians mentioned in the first project here. So regarding the perceived benefits of CT screening for lung cancer, we can see that on the right-hand side of the 24 screening participants, half of them, 50% of them mentioned early detection and curability of cancer as the benefits of CT screening for lung cancer. Most frequently, they mention possible identification of comorbidities, followed by health education information. However, for the 12 physicians, majority of them mention early detection and curability of cancer, followed by possible identification of comorbidity and health education and information being the least. But overall, among the physician and also screening participants, majority of them found lung cancer screening to be either more important or equally important as other type of cancer screening. So when we present the two strategy for explaining the screening benefits, the first one being 4 out of 5 people with screen detected lung cancer will still die of their disease. And the second, it's 4 out of 5 people with screen detected lung cancer will be cured of the disease. So we presented these two strategies to both the physicians and the screening participants. And of the majority of the screening participants, 83% of them, and found that no matter what, these two strategies actually did not affect their decision to be screened. And only 4 said that it would impact the decision to get screening. Of the physicians, 92% of them felt that this dichotomy is framing the benefits was confusing. And oops, the screen changed for me. And 50% of them said that they don't use this kind of frame to discuss the benefits of screening, and they relied more on their own clinical experience regarding lung cancer screening and how curable lung cancer is they found early. In summary, we found that physicians are confused about the overall extent of the magnitude of this benefit of lung cancer screening, even among those who are currently already referring their patients, and this might impact their communication strategy. Among patients who are willing to be screened, and just the idea that there is a benefit, potential benefits is already sufficient. Overall, these results suggest that it will be useful for major organizations to have a clear message to their physicians regarding the magnitude of the benefit, as it is confusing even to those that are those physicians that already inclined to refer their patient to screening. So the next area that I'm going to talk about is risk modeling. Risk modeling can be used in a variety of area, but for this talk, we're going to focus on applying for risk stratification or risk assessment. So traditionally, we would take the clinical data of a group of population or for participants and use that clinical data to stratify the patients into whether they are low risk, high risk, moderate risk of lung cancer screening. But more recently, a lot of models have been built to integrate blood test results, tissue sample, and also imaging data to further improve this risk stratification. So the first topic among the risk prediction model was what I presented last time at our I-ELCAP conference and also presented at the STR. So I'm not going to go into detail here, but we have developed a 3-year lung cancer risk prediction model specifically for people who are exposed to secondhand tobacco smoke. And in our model, we were able to, we use a quantitative secondhand tobacco smoke exposure score. And in our clinical model, we were able to show that some of the never smokers in our study actually had similar lung cancer risk as smokers who qualify for annual lung cancer screening. By integrating CT imaging into the clinical risk model, the performance of the risk model significantly improved. So at the end, we propose that we can offer lung cancer screening, a one-time single CT scan to these never smokers, and use the integrated clinical and imaging risk prediction models to calculate based on their CT findings, the first CT scan CT findings, and to modify their score of lung cancer risk and decide whether they should continue screening or not. So this year, the researchers at MIT have developed a deep learning model, Sybil, that analyze scans and predict lung cancer risk within 6 years. And it requires only one CT scans and does not depend on clinical data. And our plan is to validate the Sybil model using I-ELCAP data, particularly looking at their performance on participants that have secondhand tobacco smoke exposure. So blood-based liquid biopsy have been used extensively for late-stage disease, and a number of studies have shown that circulating tumor cells and circulating cell-free tumor DNA can serve as an effective tool in cancer diagnosis and prognosis. So it can potentially be a biomarker for early cancer detection. So we work with Lung Life AI to explore the use by integrating these Lung Life AI additional information and see if this information can further help with the risk prediction model. We also work with Orbit Genomic. They are currently analyzing DNA extracted from lung cancer cases and non-lung cancer cases from blood samples collected from Mount Sinai participants. And the goal of our study is to optimize and validate their microsatellite-based risk classifier and identify microsatellite foci that have information about cancer risk. They're currently also looking for additional partners. If you're interested, you can talk to Dr. Nikolowitz. At last, for risk modeling, I want to briefly mention that we're currently working on a multi-omic prediction model for lung cancer risk. We're working with the Oak Ridge National Lab, leveraging the computational capacity of Oak Ridge National Lab to analyze massive amounts of data from clinical exposure, lifestyle, genomic imaging information that's available through the I-ELCAP, the Mail-in Veteran Program, and also the VA. We're working to integrate all these information and to build a new risk prediction model to hopefully identify those who are at high risk of lung cancer that are currently outside of the screening guideline. So next, I'm going to move on to atypical pulmonary cysts. So if you're aware, the latest 2022 lung rats added a classification criteria for cystic nodules. Depending on these features of the cystic nodules, they can be categorized into lung rats 3, 4A, and 4B with different recommendation for follow-up. We're working with them to further understand these cystic nodules. Primarily for the first project, we'll look at the inter-reader variability of these new categories for the cystic lesion. And our second project with them is to understand the progression of these cystic lesions. Multiple readers will read multiple scans at multiple time points on an assigned as category. And so we will also determine the optimal time to intervene these lesions and look at the outcome of these cystic lesion. So now I'm going to hand over to Artit to talk about measurement uncertainty.
Thank you. So in the interest of time, I'll just give you a little bit of a preview of what some of this work that we're doing on nodule measurement uncertainty. And I'll start off by this sort of rhetorical question of, do you think we can measure these nodules equally well? So here we have a small isolated solid spherical nodule, one that's attached to the chest wall, one where the borders and shape are a little bit ill-defined, and these other two nodules that have a much more complex morphology. So as you think about, so some of the factors you're probably thinking about in your head are, are they attached? What does the border look like? Thinking, depending on what properties the nodule has, maybe you can't measure them as well. And when we talk about what does it mean to measure well, I'm going to briefly just talk about precision versus bias. So what I call measurement uncertainty is sometimes referred to as precision in statistics. And if you think of it as a bullseye, where the center of the bullseye is your true value, on the upper left of the bullseye, you have a wide spread, and the center point of those is not quite at the center of the target. So that would be low accuracy, low precision. On the next one to the right of that, you have low accuracy because they're not at the bullseye, but have high precision because they're all clustered closely together. And in the bottom right, you have high accuracy and high precision where they're all clustered closely together and they're all on the right value. And the kind of statistical view is on the right, where I'm showing a Gaussian distribution. The mean of the Gaussian, how that differs from the true mean, is your bias, and the spread, the standard deviation of the Gaussian, would be your uncertainty. And the reason why we care about this is because in nodule measurement protocols, they all use size and growth rate as determining factors of kind of what to do next. And this flow chart is from I-ELCAP. I just wanted to show just about all the other protocols, nodule management protocols, make use of a growth rate in the sense of doubling time, along with some ACR uses a size threshold, but they're moving to using volumetric growth measurement. And the question is, going back to that earlier slide where you had those different kinds of nodules, where you probably thought you can't measure them all equally well. None of these protocols really take that into account. The Nelson protocol kind of tries to take into account the idea of uncertainty by saying, well, anything with less than 25% change counts as a negative finding. But the 25% is sort of an arbitrary, somewhat arbitrary amount measurement. And as an example, what it might look like clinically, here's a nodule. The boxed region is the nodule there, and what I'm showing on the next slide is several slices of that region of interest. So this is nodule at one time point. This is the one at the second time point. And you can just see, just by counting the number of slices, the one on the right is on at least 2 additional, maybe 3 additional slices. So each slice in this case is a millimeter. So you're looking at 2 or 3 millimeters different. But what if I actually told you that these scans were taken only a couple minutes apart? So really the nodule should not have grown in that time span, but here it does look like it is. So we wanted to investigate this, and we have a database of biopsy cases from Dr. Yankelevich at Mount Sinai. This is the highest quality, best case scenario. Patients coach on their breathing, so the inspiration should be the same. They stay on the table, so there's no position difference. Same scanner. It's a high quality thin slice protocol. And we had 107 of these nodules. I'm just going to show a couple of examples. Here's one where we're looking at the 3D representation in the white. And there was a difference between the smallest and the largest of 37%. And again, these were done during a biopsy, so there really should be no change. Here's another example where the nodule, again, this is also about a 30% change in volume, even though the nodule itself looks a little bit cleaner in a sense than the previous one. And in case you thought maybe it's something to do with the shape, here's one that has a kind of a lobulated shape. And this one had a much more consistent measurement, where the smallest to the largest had a difference of 2%. So the goal of this work was to try to figure out exactly which factors and how much they influence the uncertainty. And this was actually accepted as a talk at IASLC World Conference on Lung Cancer in Singapore. So to find out what the actual results are, you'll have to listen to me talk there. So, and I just wanted to also mention this work was funded by a grant from the Prevent Cancer Foundation. Thank you, Bo. And turning it back to Rowena.
So finally, the last topic that we're going to talk about is the impact of duration follow-up. diagnostic follow-up and prognosis. Focusing on the solid nodules, usually workup, which is usually the most aggressive ones, protocol generally provides three main options for workup based on size. If the nodule is very large in size, the probability of malignancy is so high that we usually recommend immediate intervention. So if the size is so small, we are comfortable and pretty confident that the probability of malignancy is so low that we will continue to follow up annually. So that leaves us with this intermediate group, which usually is ranged between 4 to 20 millimeter. And the management of these nodules focus on gaining additional information about the probability of lung cancer. So that can be obtained in various ways, but the dominant approach is to estimate whether that nodule is growing at a malignant rate. Here shows some of the management protocols for solid nodules that's seen on baseline in different countries. You can see that the protocols differ as to size, how they follow up these nodules, but generally for size ranging between 4 to 20 millimeter, they recommend 3 to 6 months follow-up. So the weakness, as pointed out by Artit in 2012, the weakness of this strategy is that we don't know about the harm, which is what is the change of prognosis for a patient that have to wait 6 months. However, empirical data for determining the optimal schedule for imaging is lacking, and protocols are primarily determined by consensus opinions. So the optimal time interval for obtaining a follow-up diagnostic scan and also depends on nodule measurement accuracy. The greater accuracy, the shorter the follow-up time to confidently measure growth. Conversely, if there's no harm in waiting, a longer follow-up time would always be better. So there's always a balance between accuracy of growth measurement and the decrease in prognosis. So there are studies that looked at the impact of delays in treatment. Recent meta-analysis found that it could not be quantified due to heterogeneity and methodological flaws. Also, the largest lung cancer largest studies in the US using the National Cancer Database reported a 3.2% increase in mortality per week of delay, with greater impact for early stage than late stage. And similar trends has been found in the national cohort study in Taiwan. So this study is actually has been published in the JTO this year. I'm not going to go into detail of the methods and all the results here because of time. But for a given nodule size, we can calculate a change in time over change in size over time based on the nodule growth rate. In the paper that we assumed a fast-growing nodules have 60 days following doubling time, moderate has 120 days, and slow-growing has 240 days. And based on our paper, we said that using I-ELCAP data, we can now estimate the change in lung cancer cure rates due to the delay for follow-up based on different initial nodule size and nodule growth rate. So this is a summary of our result. You can see that in the first column, we list nodule size, initial size from 4 millimeter on top all the way down to bottom 20 millimeter. And the second column shows the initial lung cancer cure rate, the 10-year lung cancer specific survival for that particular nodule. And column on the right shows that if the nodule, if we delay the follow-up by 3 months, 6 months, and 1 year for specifically slow-growing nodule with an S, moderately growing with an M, and fast-growing nodule with an F, how much of the absolute decrease in cure rate it would cause. So, for example, for a 4 millimeter nodule with an initial cure rate of 96%, by delaying 1 year, for a slow-growing nodule, it would decrease the lung cancer cure rate by 1.7%. For a moderately growing, it would decrease by 4%. And for a fast-growing nodule, a fast-growing tumor, it would be decreased by 12%. So we can see that for a small, moderate, and slow-growing nodule, the lung cancer would still be remaining in a pretty highly curable lung cancer survival in 1 year. But for fast-growing lung cancer, its cure rate would have decreased dramatically in 1 year. So if we look down the column, we can see that the impact of time delay increases with increasing nodule size. So in summary, benefits of any biomarker test needs to balance the added benefits of early diagnosis against the potential increase in false positive and false negative diagnosis. The impact of time is greater for larger nodule, although the impact of measurement error is less. The ability to predict whether a nodule presents, whether it's a fast-growing nodule or slow-growing cancers should become a priority in protocol development. So lastly, I want to highlight that these are just give you a taste of some of the recent projects that we are working on. Dr. Henschke will be presenting more recent projects in the conference. Thank you.